Very good afternoon to everyone. So I think so Dr. Ashish has covered most of the things. Since NTRK TKI we are using very less, and the mechanism of resistance, but it's the drug of future. So we should know how it is going to, the patients are going to respond to it, and how other ways resistance is going to develop, and what we have in our basket for the future in this group of patients. So this has already been discussed because TRK mediated downstream signaling, it works basically by the RAS-RAF maker pathway, or by the PIP3K pathway, or the PLC gamma pathway, which it acts, and the neurotransmitters which are the NGF, NT3, and BDNF binds on this TRK A, B, and C, and then it goes further. So despite a prolonged response, as has already been told, is something around 35 months of PFS with larotrectinib and a PFS of around 18 months with entrectinib, many patients treated with this first generation eventually progresses. So as we have already discussed about the response, so it is something around 30 months in the larotrectinib with entrectinib around 11.2 months. So that I'm going directly to the mechanism of resistance. It is basically, there are two types of resistance which occurs in this. One is the on-target mutation. The other is the off-target one. So the on-target mutation is the mutation which occurs on the TRK, that is the tyrosine kinase domain. And it may be acting on that domain, which it causes the and affecting the downstream signaling pathway. Whereas the off-target one, it is affecting different bypass pathways, which are the KRAS 12 GC pathway, KRAS pathways, or the BRAF pathway, or the MET amplification, which is going to affect in these group of patients. So coming to the on-target resistance mutations. So there are basically three types of this on-target, and one have to now remember, because in almost all the TKIs, these are the common pathways which are affecting the mutation. The first of it is the solvent front mutation. The solvent front, as already discussed earlier by Akhil, is about the pathway which is affecting the hydrophilic portion of the NTRK kinase domain. It affects, and the mutation occurs in this. And in the NTRK, the most common mutations are G623R or G595R, and it is mostly homologous to those occurring in the ALK and ROS mutation, like G1202R mutations in those. The other is the gatekeeper mutation, and this gatekeeper mutation is the mutation which is affecting the transformation of the ATP. It's a conversion inside the cells, and if your mutation is occurring in that domain, it is the next common mutation. And the third is the XDFG mutation. It is basically the amino acid change in the tyrosine kinase activation loop. So it is basically the structure of it is the X-ray crystallography which is taken of the tyrosine kinase, and it affects at the different levels. And the most common is surely the solvent front mutation, which occurs in this group of patients. So there are various receptor variant, as may say this, like the insolvent front, it is affecting the NTRK, all the three pathway, NTRK 1, 2, 3. There are different mutations occurring in this. And even after entrectinib, you can go with other molecules which are in the second generation coming, like selitrectinib and repotrectinib. And so similarly in the DFG, there is a different mutation profile which occurs in this group of patients. So how to test for these mutations? So one may have to go for the TRK resistance testing methods, and it involves testing both the plasma. The mechanism at present uses a Garden 360, or from the tissue as per the local standards you are taking, and you can test both of these in this group of patients to know which mutation the patient is having. So at present, how to treat these group of patients? So initially in the first generation the TRK inhibitors, entrectinib, larotrectinib you are giving. Sometimes there is a false positive testing in this group of patients, so you have to also be knowing whether it's a primary refractory or it's a false positive from the baseline, that there is no TRK inhibitor, still it has shown that. And on treatment, whether if there is a progression, if it's a oligo or solitary site progression, then you may go for a local therapy initially upfront and continue the same agent. But if there's a resistance in the different domain, as we already discussed about the solvent front gatekeeper or others, so you have to look for the resistance which is going, and then you can go for the second generation TKR inhibitors of repotrectinib and selitrectinib in this group of patients. Whereas for the off-target resistance, whether it's a KRAS mutation, MET amplification, BRAF or IGFR, so you have to treat according to the standard of care which is available for these group of patients. So the next generation TRK, so this is the coming after larotrectinib, there is a study about selitrectinib. For entrectinib, there is a repotrectinib. The beauty of these molecules of second generation are they are smaller molecules, and they can bind in between the ATPs, so they can act on that way. So this is the X-ray crystallography structures, and it is in the site, in the activation loop where they are going to bind. Because of their smaller molecule size, they can get incorporated, and therefore they can overcome the resistance in this group of patients. So the molecules, the selitrectinib, which is a second generation tumor, and the beauty of it is it acts even in the more than 1 month of child has been taken in this study with solid tumor who are made have relapsed after the initial therapy with brain or brain without brain mets. The phase 1 study has been taken as with the primary objective of to find the recommended dose for the phase 2. And in the phase 2, the primary objective was overall response rate. And in the initial, the drug dose was taken as 43 milligram per meter square, which if less than 12 years, or 100 milligram BD for more than 12 years. And thereafter, the phase 2 study has been taken around the recommended dose. So what we see is that the compassionate use access of this drug has clearly shown that the maximum benefit was seen in the solvent front mutation patient. That is 50% benefit was seen. Overall response rate was in this group of patients. In the gatekeeper mutation, it is 25%, and in the XDFG also there is a 50% response, though the number is very small. But still, the type of mutation which is occurring may show the different response in this group of patients. Regarding the toxicity profile, the most common toxicities are, like in earlier drugs, were also dizziness, ataxia, nausea, vomiting. But there are the dose-limiting ones of these are only these two. There is no dose reduction is required in only one patient without any discontinuation in any further patients. The next drug was repotrectinib, which is a second generation again, and it has also been studied in ROS1 positive tumor along with the NTRK with the primary endpoints of overall response rate. And we see that the confirmed overall response rate is something around 40-41% in this group of patients across all different tumors, as we know that the NTRK can be used in multiple tumors. So every tumor in the second line showing a response rate of 40 to 41%. This is the thing in the TKI naive. And even in the TKI pre-treated patient, the overall response rate is sometimes higher. It is something around 54% in this group of patients. And regarding the toxicities, it is more the grade 5 dyspnea is the only seen in one patient. Otherwise, the dizziness is the most frequent side effect, along with ataxia, dizziness in this group of patients. So what we have seen is even after this is a case of a very serious salivary carcinoma in which there was with NTRK is mostly expressed, it is more than 20% in this group of patients. So even if this patient has not responded to entrectinib, progressed on that, after repotrectinib, there is a very great response in this group of patients. Regarding the off-target or bypass pathway mutations, so it is being seen if there's an on-target mutation, you will surely change. But if there's an off-target, if there's a BRAF, KRAS, you may go with the standard of care. But if there's a MET amplification mutation, in that case, with selitrectinib, you can add crizotinib in this group of patients. So the double TKIs comes in picture in this group of patients where you can use it. So this is just a case where it has been also shown that this is not related to lung, but it's still where the NTRK mutation is present. That if a 7-month-old child was there, he has been treated for a mass with a VAC, and after that it's found to have an NTRK mutation. The patient has been treated for something around 1 month, and after the treatment has been stopped when the disease is under control. Soon after stoppage, there is a progression of disease after 6 weeks, and again you restart the treatment. There is again a response coming after this. So this drug can also be reintroduced if it has been stopped in initial cases. So how to manage? Just the key points. There's multiple mechanism of resistance are there to the TRK inhibitors. You have to rebiopsy all these patients, or you have to take a liquid biopsy or do a circulating tumor DNA. For those with on-target resistance, investigational next generation are a promising option, and those with off target, you have to take the standard of care in this group of patients. Sometimes tumor flare can also be seen when you stop TRK inhibitors. So in that case, you have to add another, whether it's a MET amplification or you can consider a combination therapy. Thank you.
Thank you, Dr. Amit Kumar, for a really wonderful presentation. Actually, I was just discussing with Dr. Vijay, all the speakers actually gave justice. This was such a rare thing. Even I was thinking what the speakers are actually going to tell. But really, they comprehensively have summarized so many points. I think we are going to keep these as a fixed speakers next time onwards. So they can just make some slight changes in their PPT and they can present. So just to take a break, because through CRSF, we are generating a lot of data, and actually what we really want a percolation in the entire oncology community, easy accessibility for the same. So that's the reason why we are going to create,